as a cat. I can't remember how old it was. I think it was like around like an 8-year-old female neutered domestic short hair, but it kind of looked like a Bengal. And it was quite a fat cat, but became quite anorexic for a period of time, and lost almost half of its body weight over about a month or two. And then it so it became quite unwell then and was very jaundiced. Ended up being a case of chronic pancreatitis and hepatic lipidosis.
Okay.
So that's kind of where the emphasis on, getting this cat fed. So it kind of started. So we kind of put an O tube in and started feeding. Well, actually, we put a nasogastric tube in because it was so unwell we couldn't anesthetize it. So we did it under a very light sedation to start feeding it. And we fed it like a sustagen mix. So it wasn't a complete diet, but just trying to get some nutrition. Then we, as soon as we had some kind of stability, after 24 hours, placed an O tube and started feeding it properly. But as soon as we started feeding it, we just started losing potassium and phosphate so quickly because of refeeding syndrome. It became quite critical. So we had quite a lot of people working on that just to try and get the right levels. And there was some debate there, and Anna will probably have an opinion on this as well, but Liz and I were kind of like aiming at just trying to, every time that we were seeing kind of refeeding syndrome, we would drop the proportion of the diet by about 30% and reassess.
That's interesting, yeah.
Yeah. I wasn't sure, what you guys would do with that one, but that's kind of what we were doing. And it took about 4 weeks to even start getting like to a point where we were quite happy with refeeding syndrome kind of slowing. But the cat's doing really well now, but it was a long one.
So what are the principles of preventing refeeding syndrome in the way of feeding? Like you've got an animal or a human that's seriously starved, as a lot of prisoners of war were after the Second World War, and Jewish prisoners as well. So how do you avoid that happening? What's the principles of feeding to avoid that happening? And what kills them?
Is it the hypokalemia that kills them, or the
Actually, I didn't realise they became hypokalemic as well, but it's the hypophosphatemia that causes the the hemolytic anemia.
Yeah.
And that kills them quickly. And they didn't realise this until they were rescuing these people from these prison camps, and they were dropping dead. But the idea is to feed a high protein, low carbohydrate diet. So that, because the principles, what's happening is there's so much ADP hanging around that was never converted to ATP because there was no energy there to do it with. So as soon as the energy became available, there's this massive conversion of ADP to ATP, which used up a phosphorus molecule each time, and it caused hypophosphatemia. But I'm interested that you had one because I've watched for it in a few cases we've had and never seen it. So
this was spectacular. It's crazy.
I guess you start, that cat's really, really extreme. So even starting on a really low percentage of calorie requirements, like I'm sure most people, when they put a tube in, like we'd always start at 25% of their RER and then slowly work it up over a week. So I guess that helps to protect them from that hypophosphatemia and those huge insulin surges that are going to drop their glucose. I don't know if your cat was hypoglycemic, Josh, but sometimes they'll get that huge insulin spike in response to the carbs. So I guess that really slow reintroduction, maybe Jeff in clinic, helps to prevent a lot of them that we'd see. But apart from that one, that was obviously really extreme that you had.
That's where the hypokalemia comes from, the insulin surges.
Mm.
Yeah, so in other words, the low carbohydrate diet. So I think I'd have to look at the constituents of, what did you use, sustagen, was it?
Yeah, that's what we had at first. We've got not Ensure, a different one now. That's meant to be-
Ensure Plus. Oh, there's
Clinicare.
yeah.
maybe Clinicare. Yeah, that sounds familiar. Hang on, I'll find it out. I got a message about it the other day. Haven't used it yet.
And I wonder, Josh, because I'm similar to Jeff in that I've had lots of jaundice cats that have put tubes in and refed them, but I've looked out for it but never had refeeding. I just wonder, with the background of pancreatitis, was some of these cats can be really brittle with respect to diabetes as well. Was there any indication there of an endocrine malfunction as well?
Yeah, interesting.
I don't think there was in this cat.
Okay.
Oh,
Can you hear me? Hi.
Yes.
Sorry.
Hello.
Sorry.
Yes,
I hope Josh has apologised on my behalf for this morning.
Yeah.
Thanks. I don't think there was in this cat, but I have to say I managed this cat only for one day of its many day hospital stay. So I don't know it as well as Josh does.
Mm-hmm.
But I don't think so. And in fact, one of the main triggers of the refeeding syndrome is increased like insulin.
Yeah, and utilization of it. Yeah. Mm.
Yeah, exactly. So for the glucose to get into those cells to then transform the ADP into ATP, that's the glucose has gotten into the cells, and that's because of an insulin surge. So I think in diabetic patients, particularly feline diabetic patients with an insulin deficiency, there'd be a lower risk rather than a higher.
That's true.
Unless you were giving exogenous insulin, in which case a really similar phenomenon happens with phosphate, doesn't it?
Mm-hmm.
Where, the DKA cats, where we drop their glucose too fast.
Yeah, that's what I was trying to put together was, we drop them too fast, they get hypophosphatemia and then hemolysis. So it was like, I'm trying to put it all under one umbrella, but I'm missing something.
Well, the key thing is the insulin. So we get that syndrome in DKA when we give exogenous insulin, and in refeeding syndrome, it's when we trigger endogenous insulin. But same theory.
Yeah, okay, cool.
That's a good case to discuss, Josh. Good.
Yeah, we were just talking about interesting dietary cases recently, and that was the first one that came to mind, which we're still managing now. We've only just gotten to the point where we can start lowering the potassium supplementation. Interesting as well, we found initially, and I'm not sure, again, it's so hard to know, I guess, if it's the changes we're making or if the cat's just getting better, but we were initially feeding MD diet just to kind of keep things really stable for this patient, but we just couldn't get the phosphate into the right levels with the amount of food we could actually feed without causing further refeeding syndrome by increasing the amount we were feeding. So we ended up switching to AD slowly with the exact same kind of caloric intake that we were giving with the MD, and that fixed the phosphate. But super interesting.
Do you remember why we chose, obviously MD for the impacts on insulin, like it's a low carbohydrate diet, it causes a sort of low glycemic peak. But do you remember what other kind of supplements are in MD as opposed to other foods which helped with the liver, with the hepatic lipidosis?
Yeah, doesn't it have, you're right, your L-carnitine and taurine and all that kind of...
Exactly right, yeah.
Really,
and what do they do?
I think, aren't they to do with fatty acid metabolism?
Awesome.
Something along those lines. Sorry, I can't remember exactly.
No, that's fine. They're cofactors in the mitochondrial shuttle, which facilitates packaging up of lipids inside the cell and kicking them out of the hepatocyte. So when you've got a lot of fat inside the hepatocyte, you need more taurine L-carnitine to help kick it out. So they're part of the mitochondrial shuttles that help with fat metabolism. So in hepatic lipidosis, obviously really advantageous, and in fact, most liver diseases or hyperlipidemia is quite advantageous.
Do the diets like AD or recovery have those at the right levels as well, or are they not so much? Do you know off the top of your head?
I don't know off the top of my head actually, but I remember doing the research as a resident and having a patient with hepatic lipidosis and choosing MD over AD and recovery for that reason, and also the impact on insulin. Yeah.
AD is fairly high in fat, I think, isn't it? But I'm not sure about its glucose content.
Yeah, maybe that was it. Good case.
Yeah, that was really cool. The amount of potassium we had to supplement as well, I guess, because there was no real minimal oral intake, but also the total depletion of body potassium and the shifting of potassium. I guess that kind of means we have to supplement so much. But I was with this case, I remember being quite amazed with how much potassium we were supplementing orally initially. That was one thing that stood out.
It's pretty amazing work. Yeah, when there's an intracellular deficit, it's amazing how much you need to put in to fill it.
Yeah, that was a good learning experience for me, just realizing how much you actually consider going to.
How's the cat now, Josh? Is it eating?
Yeah, so it's eating on its own. I guess another interesting part of that is it's been coming back weekly now, more so because the owners were at their kind of financial limits. But it has been quite stable and still has its O tube in, and they're feeding about 30% of its RER through the O tube. Okay. But the cat's now eating on its own and kind of apparently sneaks around and eats food kind of back to its old ways, and it's putting on weight quite well. So assuming it's getting enough intake.
And are you continuing to monitor its electrolytes weekly? And then you'll just tinker with its oral supplementation from there?
Yeah, so we've been monitoring its electrolytes as well as phosphate weekly at the very least, and kind of intermittently checking its liver values, which have now, I think, pretty much normalized.
Oh, amazing.
Wow.
Yeah. But its phosphates and potassium are now normal, and I think the potassium only just came into the normal range, even after supplementing. I can't remember, it was like 12 milliequivalents like every 6 hours or something like that. It only just come back into the right range after like a month.
Wow.
Yeah.
The ADs are high in protein, fat, carbohydrate, omega-3 fatty acids, branched chain amino acids. Just having trouble finding the, but yes, certainly high in fat, and it was about 30% fat, I think. And here we go. Protein 44% dry matter, fat is 33. Carbohydrate, NFE, I'm not sure what that means, 13.2%. So potassium,
NFE?
1.15. Yeah, I'm not sure what that is, capital N, capital F, capital E.
Non-fermentable, maybe? E? I don't know what the E would be.
No, it's got me too. So, I mean, 13%, if it's 13% sugar, that's pretty high, really.
Yeah.
But
it's a good segue into a really good resource through Wasava, which once so I'm 15 minutes away from work, I'll post a link to it in the chat group. But it's just all of the nutritional resources in 2 A4 pages of links. And it's just got all like heaps of diet information, heaps of client information, like websites to direct clients when they want to feed raw food and stuff like that. And it's Yeah. So when you've got these sort of questions like, oh, would that diet be appropriate? It's like a really good resource. But also the other good resource, which hopefully like general practitioners have access to, are the food companies and the reps. And they've helped us out a few times with patients with like renal disease and diet intolerances and things like that. They've helped to kind of find the middle ground.
Yeah.
Jeff, are you guys using nutrition consultations in people? Or, you know, if you've got a client that comes in and says, oh, I'm just doing a home-fed diet, what sort of recommendations do you make?
Well, I'm probably the wrong person to ask that personally. I usually suggest they switch to something better balanced.
Yeah.
Without trying to recommend any particular brands.
Yeah. And if they're insistent on a home-cooked diet, do you just leave them to it?
That hasn't come up with me personally.
Oh, good.
But wouldn't be the right approach.
Anna, have you referred anyone to the like Sydney Animal Nutrition?
Sydney Animal Nutrition? No. I haven't even heard about them.
I don't know. It's not owned by a vet, but I've had a couple of clients at Lagola that have used them. It's I think the lady is a registered veterinary nutritionist, but I must admit, I don't know what that means. And you just pay like a little consult fee. I don't think it's particularly expensive, and she'll give them.
Oh, wow.
I wanted to ask one of my clients for their report for this talk, but I haven't got it yet. But a couple of our clients have got a report from her that it's called Sydney Animal Nutritionists.
Yeah,
like them like a meal plan. I was just wondering if that's something you'd used or what you do in this situation.
Well, we use a group in New Zealand who were at New Zealand uni, and we just basically they do a big long diet history, that the questionnaire that the owner has to fill out.
Yeah.
And then the owner has to write what their objective is, like if they want to do home cooking or if they want to avoid food allergy and things like that, and they'll make recommendations for home cooked diets for them.
Oh, cool.
But if there's one that's local and I think it's $290 or something, this other one, it's just a hard sell. People are like, well, I can't see any problem with what I'm doing right now.
Yeah, that's exactly it.
Yeah, so it would be good to have a second resource. Most nutritionists, if they're calling themselves nutritionists, they have to be specialists.
I think I don't think she's a vet, but I think she's got like a master's or a degree in, because I remember looking her up before in animal nutrition, I guess.
Yeah. Right. Okay. Interesting. Who knew that was a thing?
Yeah, I'll send you a link or I'll put it in the chat. And I think it's like
$40
for a recipe plan and $80 for a consult. It was like normal, what I considered like
very reasonable. Yeah.
She's
awesome.
She's working marginally according to the Veterinary Practitioners Act, I think.
Oh, really?
I would think so. I mean, the board would have to rule on it. But if she's charging a consultation, it could be argued, I think, that it's a veterinary fee and that she has no right to charge that.
It depends what she's calling herself to. I guess if she's calling herself a nutritionist, that's misleading. But we don't know that until we look at the website.
No, and it's not our concern either. That's
exactly.
the board's concern.
Ignore, yeah.
We've been using University of Missouri.
Oh yeah.
And the information is quite detailed too. I think it's $200.
Is that the pet foodology? Place?
No, that was just the University of Missouri. There's a nutrition department, I think.
Oh yeah, right. So if we want to sort of talk about different disease processes that we see and how to manage them nutritionally, do you reckon that's a good approach for the rest of the session?
Yes.
Yeah. Do you want to? I think protein losing enteropathy is a really interesting one to talk about, because it's one that potentially applies to emergency GP and medicine specialists. So as far as if we sort of look at the components of food that we need to feed these patients with protein losing enteropathy, we're going to look at protein. Do we want to feed them a high protein or low protein diet?
High.
Traditionally low.
It feels like a trick question, but I would say high.
High digestible protein.
Very good. Who said that? Was that Tom?
Max.
That's the golden star.
Max. Oh, Max, the golden child. So that is absolutely the key, highly digestible. So your instinct is with these guys to dump protein into them to get their albumin up, because they're losing protein via their bowel. But if a sort of key concept in gastrointestinal disease is that if you've got protein that doesn't get digested and then it's still in the lumen as it goes through the bowel, it's actually going to cause more inflammation, cause edema of the bowel wall in the distal bowel, and actually act as an osmotic agent. So it's going to draw fluid into the bowel, and it's going to make diarrhea a lot and motility problems a lot worse. So there's no point dumping a high protein diet into dogs who don't have the capacity to digest it inside the gastrointestinal tract, so and then absorb it. What about fat in these guys?
You want them on a low fat diet?
Yeah, so you want to go pretty low. Like, I know a lot of them are pretty poor condition, so it's hard to justify giving them a super low fat diet. But again, if fat is not digested properly and not absorbed at the upper GI tract, if it stays in the lumen of the intestines, it's going to cause a lot of inflammation, increased fermentation lower down, and selects for kind of more pathogenic bacteria in the lower bowel and causes dysbiosis, and again acts as an osmotic agent and causes steatorrhea as well, which is just really unpleasant to clean up. So low fat diet. And then the other two components we look at in the diet are sort of carbohydrate, but then a subset of carbohydrate fiber content. So we most commonly see dogs with PLE, so I think we should stay on dogs. But would you want to give a dog with PLE a high fiber or low fiber diet in a situation where they're presented to the vet clinic unwell?
Again, I think it's going to be the type of fiber, whether it's soluble or not. And I think you do want increased soluble fibers.
Yeah, I think probably increased soluble fiber, or you probably want to stay away from the insoluble fibers, just because the bowel is not going to have capacity to move them through. It's just harder work for it.
Okay.
What about carbohydrate? You can say no specific requirement if you want.
I think it'd have to be highly digestible, otherwise you'll have the same problem as with the others.
Yeah, absolutely. So we want to kind of give the bowel a rest, but also provide it with nutrition. So really, as long as we don't want there to be sort of nothing coming through, we don't want every single bit of it to be absorbed, which is where the soluble fiber comes in. But that's pretty much all we want left in the bowel when it gets to the back end. So carbohydrate wise, readily absorbable, but often we're giving these guys really small meals, so it's not a bad thing if they've got a high carbohydrate content potentially. My signal's about to drop out, so if somebody else wants to suggest a disease to have a discussion on, and then I'll jump back in once I pull into it.
Good.
One of the big ones would be renal disease, would it?
Yeah.
And then diabetes.
And also, Josh, touching on your pancreatitis cat, I mean, it's a chronic condition. So where do we go moving forward? We sort out his potassium, his phosphate, his immediate concerns. And then what do you feed this cat long term?
Long term, yeah. I don't really know exactly what our plan is there. But I think realistically, we just want to make sure this cat doesn't get really fat again, is the main kind of aim. And I think ultimately trying to figure out what the cause of the pancreatitis was. So we're not sure if there's some component of triaditis as well, given that in the liver. So we might look at something like a hydrolyzed protein diet, I think is what we were talking about. But I haven't actually got a firm plan in mind yet from Liz. So.
Okay.
But I can let you know once we.
Thanks, Josh. Let me know. Just out of interest, was his vitamin B levels done? Do you guys do vitamin B, or just go, you know what, just supplement because they're not indicative of tissue levels anyway?
Yeah. So this cat, we did send off B12, which I think was normal, but we did supplement with a B complex injection just because we were worried about thiamine deficiency.
Okay.
The cat
did he have neuroscience?
No neuroscience, but it was very I guess no serious neuroscience, but the mentation, you could argue it was quite flat generally. So we weren't sure if that could be neurological. So we just supplemented anyway because we know that they can become thiamine deficient too. The cat also did have quite off the scale PT and APTT. So.
Oh, wow.
So we ended up also putting this cat on vitamin K for the week it was in hospital and stopped once those were within normal. That was the other reason why we didn't do an O-tube straight away as well. We kind of wanted to wait 24 hours. And an amazing thing that I had no idea about, but one of my first questions was, how long can we expect for it to take those coagulation factors to kind of PT and APTT return into the normal range after kind of treating. And Anna said it was within 24 hours, and she was dead on.
PT should be,
It blew my mind. I didn't think that was the case. I would have assumed it would have been, a few days at least. But.
Yeah, that's good.
Yeah, I think the factor. Well, PT comes back first, I think, doesn't it? Is that 3 and 7? So I think it's 7. It comes back really fast. Is that right, Anna?
Yeah, 7's good. Yeah.
7's good. Pick a number, any number.
So yeah, 7's correct.
No, 7. It's 7. Yeah.
Yeah, good.
Yeah, that was really cool.
So 7 has the shortest half-life, so it's the one that runs out first. But they actually only need 20% of their clotting factor, like the normal amount of circulating clotting factors, to have normal PTT. So they don't have a lot of reserve at that point, but they do have a plot. So it doesn't take very long for that to be produced once the liver's got the capacity to produce it.
Cool.
So
we've lost you, Anna.
You're probably down in the car park. Yeah, that was a very interesting case.
Yeah,
I learned a lot from that one. So.
Sure was. It was great. Jeff, diets in renal disease is very contentious in respect to protein restriction or not. I think we're all happy with phosphate restriction being ideal. Do you guys want to join into the boxing ring of whether you're protein restrictors and when do you introduce that protein restriction, or do you think that the cat then becomes too cachexic and actually worsens their prognosis long term?
Yeah, what are your thoughts on?
I guess. Oh, sorry. No, you go.
Oh, sorry, I was just going to say, when I coming from GP, and from uni, the understanding that I had was as soon as we're seeing things like uremia, we want to try and restrict the protein. But I've always wondered especially in the animal, in cases like renal disease with glomerulopathy, where you have like a protein losing nephropathy as well, like what kind of plays in there? Because I'm assuming, again, you kind of want to maintain good protein levels, but I was wondering what your thoughts on that would be.
Yeah, I think that's a really good question, Josh. And it comes into a couple of things there. Is we don't see glomerulopathies as often in cats as we do in dogs, and certainly nowhere near as often as we see chronic renal disease and nephritis in cats. But I think similarly to PLE, you kind of want to give them higher protein, but actually that's more enterogenic often, and it's not a good idea to give them higher protein when they're losing it, even though intuitively you want to, is my understanding. With chronic renal disease, the argument is, well, but cats are obligate carnivores, they have a much higher protein requirement, and if we restrict protein too early, actually then their sarcopenia is much worse, and some studies are suggesting actually they don't do as well. And there's some sort of relationship between their morbidity and how much muscle they're losing earlier on. And so I think there are, and I was at over in the States at the American Feline Association, and feline specialists on stage really arguing, boxing gloves on, about is it just phosphate restriction that they require versus phosphate and protein restriction. And you've just walked in, we're talking about the debate of protein restriction in chronic renal failure in cats. And it was really interesting, Josh. It was really heated. Us in the audience were like, oh, this is awkward.
I guess they are low protein. I always also thought the prescription KD diets, like the Hills KD, is high in essential amino acids, so it's supposed to help the patient not lose muscle. Like they're still supposed to have, not suffer from severe cachexia. I don't know if that's the case. If there is cats that still really become cachexic, I can't say I've ever seen one that does, but I don't know how many owners feed their early kidney disease cat exclusively kidney food.
I think that's a big point too, isn't it? Is what else are they getting?
Yeah. Yeah. I guess they're designed, even if they're reduced protein, to have those high essential amino acids so that they can build protein. And the omega-3s and everything else that's supposed to help.
I guess it also, on a very basic level, gets back to that cat and whether they're eating them or not. Anecdotally, I think they eat, in my hands, they eat the raw cannon better than the KD. But Helen, I do see them sort of lose a lot of weight, and I really worry, is this just the underlying pathology, or is this diet related as well? And I came away from that particular meeting just going, well, like a lot of things, I think the bottom line is we don't know yet, and it maybe get down to the individual.
And were they suggesting to use a renal diet plus like a protein source, like a meat or something?
Yes, and a white meat, low in phosphorus. Yeah. So and adding fats, different fats, as you said, the fatty acids and what have you, and getting calorie there, but they need protein calories. So they were suggesting chicken, turkey, that sort of thing.
Yeah, I think that's a good idea as well, because also some of the weight loss from cats might be if they're not eating their new diet very well, making it more palatable with meat. Yep.
We all know that fat tastes yummy, so adding some sort of fat. And I guess they talked about, okay, well, instead of using a renal diet and a really severely protein restricted diet, is to use phosphate binders instead.
We just look at the IRIS guidelines with low albumin. They suggest using vitamin C and clopidogrel.
Yeah, they're prone to clotting with the low albumin. They're what is it, thromboplastin 3 or something? Anna, help.
Antithrombin.
Antithrombin 3.
Antithrombin 3. Or is that being debunked? No, there's something else as well, not just antithrombin 3 that's involved with the hypercoagulable state.
A whole heap of mechanisms in kidney failure, particularly glomerular endothelial damage, which causes microthrombi to form, just because of they're basically exposing tissue factor and activating coagulation cascade that way. But with protein losing and nephropathies are really rare in cats. I find you get a tubulopathy or interstitial nephritis in cats. So most of the mechanism in cats is going to be blood pressure, so hypertension causing endothelial damage, and then glomerular endothelial damage causing microthrombi in the glomerular. So what was if they lowered albumin, critical, and what was the other one?
Vitamin C. I don't have an explanation for that, and they don't give it. They just say, yeah, well, one of the things they say is to feed a renal diet, which is useful practically, but not telling you why.
So they're quite sort of which stage of renal disease to introduce a renal diet. Did you cover that while I was out?
No.
Yeah, that was stage 1.
Stage 1, they recommend no renal diet. They recommend continuing to feed normal food because a loss of condition, they will lose condition, they will lose protein from a renal diet. That if they lose condition in stage 1, their prognosis is much worse. Stage 2 onwards, where the benefits of the diet outweigh the hyperphosphatemia and things that would accumulate at stage 2 onwards, managed better with the diet. But stage 1 will make them worse. So I didn't actually read about renal.
No.
Okay.
I'm just looking at it now. It's actually the Ettinger chapters. It's a lot of text, I got to say, but it's broken up into like different stages of CKD, which is good.
Yeah. So why don't we put bench renal until next fortnight, because that is on the list. In fact, sorry, not next fortnight. So next fortnight, Liz is going to do a cameo post. She's got a talk on management or diagnosis and management of chronic diarrhea, which I thought was a really good kind of segue from talking about nutritional management of gastro diseases. We'll do that next fortnight, but then the fortnight after that, I've got down talking about kidneys, lower urinary tract diseases. I skipped dermatologic diseases because it's just too boring, and nutrition-related skeletal disorders. So, I mean, there's so many components to renal, and I'd like to do a bit of reading for my own reference, because like pH, calcium balance, phosphorus balance, stuff, like I think we could really go down a rabbit warren there.
Sounds good.
Would you mind if what other diseases came up when you were talking about it?
We haven't spoken about megacolon yet. We thought we'd leave that for you, but I think that's an interesting one, because I think that's something I'm sure most people will see. I certainly feel like I see it in practice.
Yeah, absolutely. So yeah, I had this cat with essentially been referred over at their insistence because their regular vet had said needs a subtotal colectomy. The cat that has a 3-year history of constipation, has strains in the litter tray, constipation, all of a sudden a nugget will pop out on the owner's bed. And they're about to have a baby, and it was just getting to the point that they needed to do something about it. They'd only been admitted to hospital due to constipation once, so it had 1 microlax enema over the course of the last 3 years, and it had been managed exclusively on lactulose and a high fibre diet.
So they were pretty keen to avoid surgery because they've got a family member that had moving out of diarrhea all over the bed instead of constipated nuggets all over the bed. So they didn't feel like that was a great solution. So I thought, as far as kind of nutritional and supplemental management of megacolon, what do you think we could do between lactulose and the subcutaneous productivity?
In my hands, I don't find a high fiber diet useful in most cats, and often it makes them worse because it just bulks up the stool. And it's a motility issue that I don't, in my hands again, is not responsive to fiber. Some can, but I do depend more on a highly digestible diet, so less residue going through that colon, lactulose, and sometimes you can then use like bisacotin or cisapride, I suppose. You can get it.
Yeah, absolutely. So 50% of cats will respond to cisapride, but you're really bang on the money with the fiber commentary. So we sort of used to use insoluble fiber or non-fermentable fiber in megacolon cats, and that was definitely the recommendation 20 years ago, because insoluble fiber increases motility and it's easier for the bowel to get a hold of to move it through. So the theory was if the stool was bulkier, it would improve motility.
And would you be able to move closer to the microphone? I can hardly hear you there.
Proud you. Sorry. Can you hear me all right now?
That's better.
Yeah, we definitely use the fiber response and the gastrobiome, that new like Hills digestive gastrobiome one that's not supposed to be, it's higher in it's moderate in soluble fibers and it's got like psyllium in it, but doesn't have a lot of the like cellulose or whatever the insoluble fibers that might have been recommended in that cat.
So that's definitely what we're moving towards. Lower insoluble fiber and lower carbohydrate and more highly digestible diet. So a lot of people with megacolon cats are now feeding just a plain meat diet, which obviously has nutritional deficiencies when given over the long term. So anything like ID in a cat, but not necessarily a low fat one, is going to be a good option. Just extremely low residue. What about options for laxatives in this cat? We're only using lactulose at the moment. Does anybody else have any favourites?
You can use things like, especially if, I don't know if you mentioned if they were cost conscious, you can use like Metamucil and pumpkin, and some cats love them.
Yep. So Metamucil's psyllium, so it's a insoluble fiber. It will increase the water content in the feces. Sorry, soluble fiber. It will increase the water content in the feces and keep it softer, which is advantageous, but it's not actually technically a laxative.
Okay, yeah, that's a good point. Yeah.
And what was the other one you mentioned?
Oh, it's not a laxative either. Just like what you can add, like at home. I misunderstood the question. Like the pumpkin and psyllium. I just mentioned 2 non-laxatives.
Yeah.
I guess a laxative that works in a different way, like lactulose is an osmotic laxative, but you could use like I don't really use them, but you could use like a one that causes like lubricants, like the hairball laxatives in combination, or like a stimulant laxative, like Dulcolax is. I don't use them very often, but
So that Dulcolax is definitely a good option first. It's a little bit uncomfortable. We find animals sometimes get cramping with that.
Okay. Because it causes contraction.
Yes, exactly.
Yeah. Okay.
Around the colon, around a very firm stool, we can certainly get just pain in a lead up to defecating. Just Osmolax. Do you know what it is?
Osmolax.
Is it like a sodium phosphate?
No, it's not a sodium phosphate. It's actually like it's called macrogol. It's just something that draws water into the feces. Tends to work. The stool consistency is more acceptable to women with osmolax than with lactulose. I do tend to use that in cats. I find it more palatable with little powder you can put on the food, and they usually eat it quite well. And I usually use that in addition to lactulose.
Okay.
What about so this cat's obese. So certainly recommend weight loss in this cat, obviously over a long period, but obesity is associated with poorer motility.
And with that obesity, increased exercise too.
Absolutely, yeah. So I recommended to these people getting a laser pointer and making the cat run laps of the house when it needs to. So that's what they're going to do. Do you use Miralax? It's a little powder that you sprinkle on. I haven't used it. Do you know what the active is?
Yeah, no, I knew that was the next question. Funny, you use something and you think, gosh, I don't even know what's in it. It's a polyethylene glycol.
Oh yeah, that's like macrogol.
Yeah.
So that will be exactly the same as the osmolax.
Okay. And then cisapride.
Cisapride is my favourite. So only 50% of cats have the neuronal capability to get increased motility in response to cisapride. But it's a miracle in those 50% of cats. So you can usually get away without surgery in those cats. Really, I probably wouldn't jump to surgery unless they've been obstipated and required anaesthetic and full enema and stuff. Like if the stools were still passing on their own eventually, I would have looking management up to that point.
And like it's not really diet, but like keeping them really well hydrated is important.
Yeah, really good point. Actually.
Like cats that you love running water, like you can get the little water fountains or like drink from their like dilute water that's had tuna or chicken in it or something like that. Try and get them drinking, keep them hydrated.
Yeah. There's no point trying to make stools softer if there's no water in the body to.
Yeah.
Adding water to their food, I found, has worked very well. They always drink it. I don't mean soak it, but just add it before you feed it. And they'll always take it.
Should we talk about pancreatitis?
Yeah.
That's something we all see. All right, let's talk about dogs first and cats second, because they're obviously managed quite differently. And obviously cats, we don't see them very often with acute pancreatitis. So a dog comes in with vomiting 10 times in the last 12 hours, marked abdominal pain, and elevated amylase lipase and a SNAP CPL. Are we going to feed them straight away, or are we going to give them a fast?
Feed them straight away?
That's the recommendation. If they'll eat, feed them. I think it's a good idea to wait for the antiemetics that you're going to give them to kick in. Because we don't want them to develop food aversion, so managing nausea. But if they're willing to eat. And why is it so important that we get nutrition in early?
It's to do with the like the microenteral nutrition. So like the mucosa needs its own nutrition, and if it's starved at any point, then you might find that the mucosa won't function properly. And I think you can get things like ileus more likely, and they take longer to recover because of their issues secondary to fasting rather than the primary issue.
Oops, they're frozen.
The old recommendation was not to feed them until I got over it, and I can't say that I noticed those things with it, but this is going back a long way. But it's certainly not considered to be wise now.
We've had it.
The older recommendation was not to feed them so as not to stimulate the pancreas, but I've seen a dog go 2 weeks without food, but on a drip, and that can't be good.
No, it has to come with downsides, definitely.
Yeah.
So I guess what they've moved towards is, rather than just not feeding, to be really specific about what we're feeding to try and rest the pancreas. So the two main energy sources for the enterocytes are glutamate up higher, and then as you move through butyrate in the colon. And both of those are short-chain fatty acids, which are made from fermentation through the bowel bacteria. So if you get a shift in motility, you're going to get a shift in bowel bacterial populations, and then you're going to get a shift in energy source for the bowel. And it might be increase or decrease depending on what's going on. But any change in energy source obviously changes the cell health. And if energy drops off, those cells are going to die off. They're going to become swollen, and we're going to lose their absorptive function. So wherever they are along the length of the intestinal tract, whatever their function is, we might lose cobalamin absorption if it's in the distal ileum. We might lose folate absorption if we're in the proximal duodenum. If the bowel becomes edematous diffusely, we're going to lose micronutrient absorption, so amino acids, fatty acids, and carbohydrate absorption, which is obviously going to impact health of the rest of the body. So then we're going to start feeding them as soon as they'll take the food. How long are we going to wait? If they're still food aversive 24 hours later after admission, how long are we going to wait before we start force feeding or tube feeding?
I don't know if there's a golden rule, but in a dog or a cat, maybe a bit sooner in a cat, maybe 3 days.
Yep. So 3 days is absolute max. The recommendation is no longer than 36 hours.
Okay, 36.
On that point, Anna, if a client doesn't come in right away and say the dog's been vomiting for 3 days and you give an antiemetic and it won't eat, should you be thinking about
Tube food.
Yeah, okay.
Yeah. So
Day one.
Yeah, exactly. So if they're 3 days into their anorexia, then tube straight away. If they're still really food averse, yeah. If they start eating fine, if they only need small quantities of food to nourish the bowel, and have things moving through.
Cool.
Before feeding tubes, are you guys using mirtazapine or similar appetite stimulants first? Is there any reason not to?
If we've got time, so often we are seeing patients when they're a few days in. So we usually use mirtazapine if they've got a functional gastrointestinal tract and can keep it down. But if it's fucked up straight away, we'll probably look at putting an NG tube in or something like that. So once we can get them eating, what are we going to feed them?
Low fat.
Low fat, perfect. Yeah.
Something, that's just going to, like you mentioned, resting the pancreas. So you want the pancreas to not have huge digestive enzyme releases. So the pancreas will release its digestive enzymes in response to food, but definitely fat and CCK, I think, in response to long chain fatty acids. So fat's like the most potent stimulator of pancreatic enzymes. So something low residue, easily digested, and low fat, like rice.
Yeah, perfect. Yep, the rice is a really good option. Good to get a little bit of protein in there, but highly digestible protein, protein that doesn't require too much protease. Yeah.
Like, I'm sure most people, just use like boiled chicken or something like that.
Exactly why we use chicken and rice. Yeah, it's a really good option for pancreatitis. It's not that great for other causes of gastroenteritis, which might be lower down in the bowel, and we're just not getting enough nutrition to that lower end of the bowel. But for pancreatitis, it's a great option. What about cats? What are we going to feed them?
I'm assuming it's just kind of highly digestible food generally.
Yeah.
But I know the kind of high fat content isn't as big an issue with cats, is my understanding. So, and I guess the other thing I would think as well is if that pancreas is relative to other diseases in the body and whether we need to treat that primarily.
So often we have cats with cholangitis and inflammatory bowel disease with pancreatitis. And they just might have more specific nutritional requirements. So obviously look at that in context. But the key point there is that cat pancreatitis is not caused by ingestion of a fatty meal. It can be exacerbated by hyperlipidemia. So we don't want to just feed them like a really high fatty diet because that's going to cause hyperlipidemia, which is going to make the pancreatitis worse. But a generally kind of moderate fat, highly digestible protein diet would be recommended.
What's your go-to like commercial diet for feeding cats with pancreatitis or choroiditis, Anna?
ID if we can.
Yeah.
I think it's kind of what ID is made for. I feel like we see less pancreatitis than we used to. And we tend to use ID for all of the gastro presentations out of habit. And it's sort of shifting away from that, and the food companies are producing things like the microbiome and things like that.
Yeah.
Formulas to address that.
If there is underlying cholestasis, would the ID address that?
Probably
Not really.
not. Yeah. Did you hear the question?
Yeah.
So ID doesn't really address cholestasis. It's low fat in itself, and we've also got decreased. So if you've got cholestasis, you've got decreased bile acids coming into the bowel to act as the detergents to help break down fats to facilitate absorption. So we've got kind of two. We've got an inability to digest fat via the pancreas and the biliary system, but we're feeding a very low fat diet. So we're kind of addressing it.
Yeah.
But it won't increase bile flow. It won't address cholestasis.
But it will help prevent further issues
from fat digestion. Exactly. Yeah. So what happens when you can't digest fat? What micronutrients?
Fat soluble.
Fat soluble vitamins like vitamin K.
Exactly. Yeah, absolutely. And the other thing that the pancreas helps with is absorption of a B vitamin. Do you know which one it is? It's not vitamin. Sorry, go, Jeff.
B12, I was going to say, but I'm not sure that that's correct.
It is correct, actually. Yeah, so B12 is transported bound to intrinsic factor that's produced in the pancreas. So with pancreatitis, we get decreased intrinsic factor, and the cobalamin can't get absorbed unless it's bound to this intrinsic factor. Like 1% of it can be absorbed unbound, and the rest of it has to be bound. So you get a really sudden decrease in your absorption of cobalamin, even though that's right down the other end of the bowel that absorption occurs, because you get an intrinsic factor deficiency. So cats in particular with pancreatitis are almost always B12 deficient, and could do with supplementation. How do we supplement B12?
Sub-Q weekly injections.
Guaranteed to get them up to a safe level with injectable. What about oral? So new data coming out, new products.
That company that make like the symbiotic I saw it the other day and I meant to look into it and I didn't. That company that make the symbiotic, I can't remember what the company's called, you know, like they have the white and grey packaging. They're making an oral B12 supplement.
Protexin, is that it?
Yeah, the reason I was going to look into it is that like, if you've got severe gastrointestinal disease, are there going to be cases where oral supplementation isn't appropriate because it's not going to work?
Yeah. So they've realised, so even if intrinsic factor is missing, even if you've got deficiency in receptors, if you give 100 times the oral B12 requirement, you will maintain normal serum levels of B12.
Okay.
And that the reason why they've come up with this is because the compliance with repeat injections, so the weekly injections required for B12 supplementation, 3 out of 143 clients or patients complied with the full course of B12 required.
Oh, wow.
So compliance is shocking. So unless your clinic has a really good system for making sure people come back, sending them home with oral supplementation might actually be better, even though there's some compromises with it.
Yeah.
And I send them home with injectable. I just teach them how to inject. And I just think, well, if they can inject insulin, which is deadly, they can inject vitamin B12. And I seem to think get more compliance that way.
Yeah, I think that's probably really positive.
Because no one likes to bring their cat to the vet. No cat likes it either.
Have you used that new Cobalamin or whatever that new supplement's called? Have you used it much yet?
Not at all. We literally got it into stock on Wednesday.
Oh, it'll be interesting to see, your results with it.
And obviously palatability is going to be a thing with cats. You know, you put powder on their food and they just say no straight away. So I will be if they do, I think it's a really positive thing. Does anybody use omega-3s with their pancreatitis patients?
Not specifically. Maybe only those in the diet.
Yeah, and often we're using diets that are formulated with increased levels. But if humans given omega-3 with pancreatitis, they had decreased complications and decreased length of hospital stay. And a lot of the life-threatening or complications we see with pancreatitis are systemic inflammatory response. So it kind of makes sense if we can limit oxidant damage and then the systemic inflammatory response associated with that. Then I think it's something I'll sort of look into with future cases. And interestingly, I've got a lot of clients who demand probiotic use with their animals with gastro signs. And interestingly, in a study of humans using probiotics, it was actually associated with increased complications. So they're not really sure why, but in humans, they stay away from probiotics with pancreatitis specifically.
That's interesting.
Because I just wouldn't ever thought they could cause harm, but in a meta-analysis, they thought they were quite dangerous.
Anna, before we leave the Cobalamin story, I read a headline, and like you, Helen, I've been meaning to go back to it, but haven't had time, of Cobalamin Excess from Supplementation. And I was always of the mind of, it's water soluble. If we give too much, I'll just urinate it out. But this was suggesting that actually it could cause a problem. Can you comment on that? Or I need to go and find that article where I read the heading.
Sorry, I thought you said Helen then. I was sorry.
I did.
I've got no idea either.
I was like,
I'll find it and let you share it with you.
Last I've heard, and that was from a presentation from the Cobalamin guy on Wednesday, was that if there's excess, it'll just get urinated out.
Yeah, that's what I always thought too. Okay, well, I'll try and find this article. I'll share it with you guys.
Yeah, and we better wrap up, guys. Sorry, we've run a bit over time. And we will see you in 2 weeks' time with a presentation from Liz.
Thanks, Anna.
Fantastic. Thank you.
Thank you.
Thanks,
Thanks, Anna.
Thanks.
Bye.